And the next speaker is his dear Basel Refky from Egypt. He's going to speak about is there a role for HIPEC in the frontline and recurrent epithelial ovarian cancer. He'll give us an update.
Thank you, chairpersons, and thank you everyone in the hall for your presence. Really nothing would have been achieved without your attendance and your participation and your discussion. It's an honor to be here today to speak in the 7th MEMAGO, and we are going to stick to time. We have plenty of time, so I can go out of time. No, I'm going to stick to time. My topic today is about HIPEC, which is a very hot topic because I see very people who are enthusiastic to use HIPEC and people who are not enthusiastic and are against totally the story. But for every story, we have pros and cons. Those are my conflicts of interest. And as we are in Egypt, in the land of history, let's go slightly through the history. As I discovered while preparing that Egyptian doctors treated tumor with heat around 500 BC. Some papers, documents dating from 3000 to 2000 BC have been found in Egypt and describe tumors and ulcers of the breast treated by cauterization and tumors of the leg by heat. The Greek also, Rhodolakis is here still, the Greek to realize the importance of thermal energy in some form of medical treatment, and the most ancient law of Moses mentioned hot spring as having some medical values. In 1866, Bosch in Germany reported the remission of facial sarcoma in a patient with a high fever due to erysipelas. And in 18s, William Cooley, a surgeon from Memorial Cancer Hospital, it wasn't then Memorial Sloan Kettering, developed the coolitoxin, which is a mixture of bacterial culture. It was used to induce hyperthermia in cancer patients. 100 years later, Westmark used total body hyperthermia with hot passes to treat inoperable cervical cancer. In 1930, tumor debulking in ovarian cancer started with adjuvant chemotherapy, and in 1969, success with aggressive regional therapy in patients with pseudomyxoma protonei. 1977, it was the first delivery system for hyperthermic intracavitary perfuse, and 1980, hyperthermia with radiotherapy treatment modality in patients with advanced cancer not responding to conventional treatment, and 1980, HIPEC was first introduced by John Spart in USA in 1980. Sorry for that. And in 1987, it was phase 1 trial, the advantage of IP chemotherapy over IV chemotherapy. In 1995, Paul Sugar Baker describes the techniques of protonectomy, and in 2000, we described the completeness of site reduction score for ovarian cancer. All of this lead to this dilemma of types and technique of HIPEC, which is not my presentation topic today, but we have the open technique, the closed techniques that we use in our center. In the photo there, we use the semi-open, and up till now we use the HIPEC is introduced in many regions. We have many pros and cons for HIPEC. Why we use HIPEC as a peritoneal blood barrier with high intraperitoneal doses, with less toxicity, and the molecular weight of the drugs that can penetrate through the peritoneum. And there is some sort of well-known IP survival advantage, which were documented by GOG 114, 172. But again, we have higher complication rates and no intervals. The role of hypothermia is that it increased cytotoxicity of the drug and direct thermal cytotoxicity. However, high dose doesn't mean better survival. Giving high dose for all our oncologist colleagues, giving higher dose doesn't mean any better survival. And those GOG trials 104, we had an outdated control arm. Cyclophosphamide was used then, it is not used anymore. So it wasn't better than the Taxol and carboplatin. In GOG 114, the benefits of IP were likely explained by the use of 8 cycles of chemotherapy rather than the 3 or 4 or 6 cycles regimen. In GOG 172, most variable now it is outdated, and there was severe toxicity, quality of life concerns, and the great majority of the participants in this trial couldn't complete the IP chemotherapy. And in GOG 252, the IP was more toxic without any benefit in epithelial overall survival. So what is the limitation of HIPEC? The limitation is that we have different drugs, different doses, different durations, different temperatures, different settings, the open, the closed, the semi-closed, and more are the small and heterogeneous single case center series. So up till now, in 2023, we don't have conclusive data. Is this real? We have different situation. No one size fits all. We have situation of the primary setting, interval debulking, and recurrent setting. And we are going to go through only randomized control trial, as I learned from my colleagues in oncology. In God we trust, but all others must bring data. It is not personal opinion. So for the RCTs, we have in the first line and interval debulking setting, we have the OVI HIPEC 1, which was done by Van Driel from Netherlands in 2018. We have the Korean LEM study in 2022, the Spanish study done in 2022, and in the recurrent setting, we have one Greek trial from Spetiulos in 2015, the Memorial Sloan Kettering by Oliver Zionovich in 2021, and the SHAPER trial, which some consider as a game changer, that was just published in the ASCO and in the ESGO and the IGCS 1 or 2 months ago. Going first through the primary setting, we have this trial, the Korean trial, LEM trial 2022, and it states clearly that HIPEC has no superiority in primary disease. The benefit was only in interval debulking. So we have no other randomized controlled trial discussing it in the primary setting, but we have future expectations. We have now the HIPEC 2 is running in many centers in Europe. It is recruiting patients. It will be closed in 2025, and so we expect the results from Nicolo to be published. I believe Gemelli has very high number of patients participating in HIPEC 2, and the results will not be published or present before 2026, 2027. But up till now, we have no rule for doing HIPEC, or we have no evidence, I can't say rule, we have no evidence for doing HIPEC in primary setting. The primary setting is primary debulking surgery. If you want to offer HIPEC, offer it through clinical trials only, but you don't have any strong evidence for that. What about the interval debulking setting after having a new adjuvant chemotherapy? There was the HIPEC 1, which was a game changer, and it was published in the New England Journal of Medicine, and all of us know what's the New England Journal of Medicine 2018. And so it started to state that there is a survival benefit. The primary endpoint was disease-free survival. The secondary endpoint was overall survival. And it stated that in stage 3 epithelial ovarian cancer, we give 3 cycles of neoadjuvant stable disease, interval debulking or complete, we randomize to HIPEC or no HIPEC, and then we give adjuvant 3 cycles of chemotherapy. And there was a significant overall survival benefit for such patient, and that's we started to propagate HIPEC as being a standard of care in the interval debulking. However, there was severe critics for this study. I believe that Ignacio Vergotti and Philip Harter from Essen, they stated severe critics about this HIPEC. That the first, the selection of the patient. They stated that the patients who are not suitable for primary debulking surgery, but there was no criteria which patients were not suitable. The long recruitment of 9 years, so we have 3 patients per center per year, which is considered some sort of hyper selection. And the selection of centers or surgeons, there is no information. Only if you have a HIPEC device, you are candidate to be in recruitment. And the randomization was done at the operation, not from the start. You should do randomization before starting giving the neoadjuvant chemotherapy, but the randomization was done after the good response of chemotherapy, and 25% of the surgeons knew about the session, so there was some sort of bias in this study. Again, the sample size was very small. It was 245 patients only, and there was only 15 days difference between the two groups. And the most important part, there was no stratification for the important prognostic factors. There was no stratification according to residual disease, FIGO 3 substage. We know FIGO 3, we have many substages from FIGO 3, the BRCA status, and the histological subtypes. For example, in the non-HIPEC arm, we had more high-grade endometrioid, we had more carcinosarcomas, we had more mucinous, and we had more metastases of GIT tumors, which are aggressive tumors, by the way, with HIPEC or without HIPEC. However, in the HIPEC arm, we have more low-grade serous, and we have more low-grade endometrioid, and so we have more favorable prognosis in the HIPEC arm. So this is some sort of bad stratification. However, this was answered from Gemelli N.G. Peters, she's a good friend, by a letter that in desktop trial there was the same selection, because some patients there was a stratification according to the histological status, so this can be done. Again, there was a very good point by Vergotti that he said in ESGO conference in 2019, that they stated that only 16 or 19 patients has got alopecia, and we all know that Taxol carboplatin causes alopecia for almost every patient. So how you have got patients who had 3 cycles and then inducing intraperitoneal chemotherapy and not having alopecia, so there was a big concern by Vergotti. And again, there was a concern about the progression-free survival median and overall survival median in comparison to other studies speaking about the cytoreductive surgery. After 10 years, just this year, there was a 10-year discussion about cytoreductive surgery with or without HIPEC, the final survival analysis of this randomized phase 2 trial, and the findings that the survival benefit in patients treated with HIPEC within HIPEC is still maintained after a period of 10 years, and this was published by Valentina Nicolo. Do you know Valentina? Again, there was a very strange finding from COLA in 2022 about that the BRCA1 and the HERD status was luckily relatively well balanced. How this balance occurred? Because we didn't do any stratification from the start, but it happened luckily that they are well balanced. But the very strange findings that HIPEC didn't improve survival in BRCA mutant and HRD negative patient. This is strange, and the significant improvement was in the BRCA wild HRD positive patient. And the authors conclude that HIPEC may be sensitive in intermediate platinum sensitivity, and that HRD is a potential classifier for HIPEC impact, and all these findings are very strange and conflicting, and they are not logic, so this should be done. In ASCO 2017, that was the start of the HIPEC LEM classification from South Korea. It was published in the Journal of Clinical Oncology, and it stated clearly that HIPEC has no superiority in primary disease. However, it has some superiority in interval debulking setting, but again, the better effect was a stage 4 ovarian cancer, which is outside the abdomen and outside the effect of HIPEC, so this was very, very concerning about that. There was a small Spanish study done in Spain by Cascal and Compo in 2021. It was only in 71 patients, more stage 4, no information in histological subtypes, no information in maintenance therapy, so mostly we can exclude easily this study. The final part is in the recurrent setting. What about the recurrent ovarian cancer? Is there a HIPEC? In his previous trial in 2015, he recruited 120 cases, but there was no statistical analysis, no trial endpoints, no consort flow chart, trial wasn't registered, no stratification, and the two arms had different lengths of follow-up, re-evaluation, 2 external reviewers failed to confirm any survival benefit, and there was no information at all about progression-free survival, so this is usually excluded from having good. And then Oliver Zianovich, and is very, very enthusiastic for HIPEC from Memorial Sloan Kettering. He published in 2021 his study about recurrent ovarian cancer, and it was a negative trial with no progression-free survival and overall survival. There is no difference, and HIPEC is adding nothing, and that was striking for the supporters of HIPEC in recurrent ovarian setting. However, just in the last ASCO, just two months ago, the SHIPOR trial, which is a new game changer trial, they stated that it's a new completely setting where it was a positive trial for doing HIPEC with impact on the progression-free in the overall survival in the patients with recurrent ovarian cancer. However, I heard this very good debate between Harter on ESMO podcast. I encourage everyone to go to the podcast. You can hear it in your car, while in your OR or something like that. And this SHIPOR trial has some concerns. Maybe it's game changer, yes, but however, it was a complete situation. Karim has just stated that the only situation of surgery in recurrent ovarian cancer is if you have the EGO criteria in this trial and then you do surgery followed by chemotherapy. But in SHIPOR trial, they started first by giving chemotherapy for the relapsed situation for 6 cycles. And if you have a response after chemotherapy, you will randomize your patient. This is not according to desktop trial, GOG 213 or SOC trial. This is a newly complete selection criteria. We don't give chemotherapy then surgery in the recurrent setting. So we should first completely new situation. We should say what is the role of surgery in recurrent and agree about it before doing this. So this is a completely total protocol to investigate the role of surgery. And the randomization was done only after complete surgical resection. So if you don't have a complete surgical resection in the recurrent setting, you will not randomize your patient to HIPEC versus no HIPEC. So it's clear that the patient will benefit. And the difference was 9.9 to 11.2 months. And the curves divert after 4 years, which is very strange. The curves remain overlapping for the first years. And then after 4 years, there is overall survival benefit with no progression-free survival benefit. And again, this is very strange. So is it a game changer? I believe no. It's a game striking just to discuss these options with us. Up till now, the situation in 2023 is that NCCN guidelines stated clearly HIPEC may have a role in interval debulking only. However, in the ESGO ovarian cancer guide, the HIPEC, intraperitoneal chemotherapy, and the HIPEC are not standard of care in all settings, either primary or interval or recurrent setting. In the ESMO guidelines, the recommendation in recurrent ovarian cancer HIPEC added to cytoreductive surgery has not been proven to be beneficial in appropriately designed studies. So ESMO is against, ESGO is against, NCCN in interval debulking. And in the gynecological cancer intergroup consensus recommendation, the intraperitoneal chemotherapy and the HIPEC, it was negative. Any form of IP therapy or HIPEC can't be regarded as a reference treatment in the clinical trials. In the ESMO ESP 2022, the consensus is not published yet, but for HIPEC, I gave you the results from the control. There was no consensus for HIPEC, not positive, not negative, still. So I get thanks from the control, Nicolo. It is not published yet. So to conclude, Is HIPEC a standard or an option in ovarian cancer? In primary debulking setting, it is not standard, it is not option. You can use it in the context of clinical trials only. You should inform your patient you are doing a clinical trial and in context of a clinical trial, not in the primary surgery, because many patients come to us to ask for HIPEC in the primary setting. For the interval debulking, we can debate if it is a standard of care or not. You can say it's a standard after OV HIPEC 1, and you can debate. And it's optional for sure, because it is in the guidelines right now, and it can be used in clinical trials. However, in the recurrent setting, I can't say it is a standard, I can't say it is option, I can't say it's still in the context of clinical trial. So in ovarian cancer surgery, cytoreductive surgery is the faro up till now, not HIPEC, not anything else, and thank you.